What's up? Okay. I thought he didn't get me. Okay, so now it's 54-year-old retired businessman came to the emergency department for fever and chills. Okay.
Mm-hmm.
The vitals, the blood pressure is 110/70, pulse rate 100, temperature is 102, respiratory rate is 15. Okay.
Mm-hmm.
Okay, so he's retired, came to the emergency room. Family report that he had mild fever, chills, body aches, 2 days. However, this morning he's exhibited high grade fever, chills, rigors, altered mental status, severe headache. He's nauseated and have non-bloody vomiting. He denies neck pain, sensory changes, weakness, or anything like that. Past medical history: hypertension, okay, and has been taking atenolol, 50 milligram.
Mm-hmm.
He denies smoking alcohol, so we don't need to counsel him on that. Family history not significant. No review of system. Everything else is fine. So how do you approach this case?
So he came to the office or ED?
Emergency department.
So let me get the case. So he's a
Yes.
54-year-old male, fever, chills, 102 fever, comes to the ED of fever of how many days? 1 day?
2 days.
2 days with AMS, headache, nausea, vomiting. Right?
Yeah.
Okay.
So what do you
So
suspect? What's your differential?
I don't know right now. And you said neck rigidity was nothing? No stiffness?
Yeah. So, but it could be, but still, like when you have fever, headache, altered mental status, could be meningitis,
I'm thinking of
encephalitis.
meningitis. Yeah.
Yeah. So what do you do right now first?
I'm gonna first start an IV access.
He's stable, so you can just do physical, really quick physical focus, right?
Okay, sure.
Scan sometimes they have.
Lymph nodes, because he has fever. You have to do the lymph and HENT because you want the neck.
Yeah, yeah. Few pink my. Okay, no, no, not this one. So you found he's alert, awake. The patient mildly confused. He appear there is a positive neck stiffness and Kernick sign. Everything else is fine.
Yeah, so it's meningitis. So what I'm gonna do is I'm gonna order IV access.
Okay.
I'm
IV
gonna give him
fluid.
hmm?
Yeah, yeah. IV fluid. What else?
Normal saline, oxygen.
There is a mnemonic I found and I remembered you. Let me give it to you. Where is it? My phone. Let me just see where's my phone.
I use Victor for the first one.
For
The
for what?
initial. Victor, V for vitals, I for IV access, C what is C for? I forgot my own mnemonic.
Hmm?
C for like cardiac, T for temperature, like give them something for the temperature, O
Yeah.
for oxygen, and then pain. Anyways,
So
go
I
on.
got I got a good mnemonic for
Tell
use.
me. Okay.
What is the word? Let me see. What is? This is like it has more stuff. Okay.
Okay.
So this is the mnemonic. It's called police bullshit. Okay, police. What
Oh
is it?
yeah, I saw this on the UL forum.
Yeah.
It's too complicated for me to remember.
Really? No, it's not that complicated. So this
Okay.
P pulse,
Mm-hmm.
pulse ox, O
Mm-hmm.
oxygen, uh,
What
the
is that?
L for lung intubation, I for IV access. We wrote that. Okay, we're gonna write it again. And C for cardiac monitor, E for EKG. Okay, and then BP monitor, B for BAB monitor, and then the one S for sugar. Okay, so IV aqua check. Okay, so what else do you want to do other than that?
Well, let's get. Well, I want to. draw blood cultures and then get a CSF. I mean, not CSF, LP.
Okay. You're going to do CBC, CMP. You want to do lumbar puncture?
I want to draw. Make sure you do lumbar puncture after the cultures. Or it doesn't matter. Never mind. It's fine. It's fine. It's fine.
Okay.
CSF. Yeah, that's fine.
What
We'll
else?
just start him on
You want to do
antibiotics.
urinalysis because it could be an infection, right? So we're gonna do
Yeah,
urinalysis.
urine culture, blood. You're not doing blood cultures?
Blood culture. Oh yeah, of course. Urine
Yeah.
culture. What else?
I want to start him on IV antibiotics right now.
What antibiotics do you want to
I can give him ceftriaxone.
do? Yeah, let's do the lumbar puncture first, and then we'll do that. What do you think? So
You don't want to delay antibiotics and that meningitis.
yeah,
Yeah.
but yeah, you can. But sometimes like it affect the culture results. So just take it. It doesn't take time to take lumbar puncture. It takes like a few seconds, and then they start the antibiotics immediately. So we're not delaying it. Like it's just 2 minutes. What do you want to do with CSF?
I want to do everything. Cytology, glucose, protein, cell count, culture bacterial, culture fungal, culture viral, all of that.
Yeah. What else?
pH, I mean, I don't know, herpes, PCR, HIV, I don't know, everything. Who knows what this guy's been up
That's
to?
heavy. What else? Anything else?
That's it.
That's it. Okay.
It's very rare to see a meningitis in a male over 50. That's very rare, right?
Really? No, can't happen. They are actually they have different regimen of antibiotics. So what do you give him?
Ampicillin,
Okay, yeah, good job. You
ceftra,
got that. Yeah, ceftriaxone. Yeah. What else?
ceftriaxone, ampicillin, and vancomycin
Yeah. Why did you add ampicillin? Smart. I like that.
to cover listeria.
Yeah, excellent. More above 50, so smart. Good job. Yeah. So
Hmm.
anything above 50, you give him.
How are your other students doing who you teach?
They are doing well. Yeah. Some of them have their exams soon. Some of them they already done with residency, so they forgot everything. So they had some like hard time with the step three. Yeah, some of them like doing for CK. So yeah,
Mm.
so they're doing pretty good. So so now what do you want to do?
Did you order everything?
Hmm?
Did you move the clock?
So how do you want to advance? How much? For how much? Now
Like
you want to admit her?
he's yeah,
Admit
we
him?
can
Yeah,
admit.
admit him.
Sure.
Yeah. Okay. So
Advance the clock for at least he's only been here 10 minutes. Like
yeah,
two
yeah,
hours or something.
yeah. Let's get the clock
He
moving.
should have stayed in the ER for at least 2 hours before we admitted him.
No, it's a meningitis case. You can just admit him.
Okay. He should be in isolation.
Yeah.
Like airborne or droplets or what is it?
Yeah, airborne. Yeah, because
Okay.
meningitis is no joke. Yeah. So the gram stain of the CSF shows gram positive cocci.
Gram positive cocci. Is that Staph aureus?
Damn, these things I always forget them. Like cocci. So gram positive. There's cocci and there's yeah, yeah. It could be either Staph aureus, could be strep. Yeah, I remember this chart. Yeah. So
Hmm.
and then CSF.
No, strep is in chains.
No, it's just cocci. So cocci and then the cluster. Some of them they cluster in groups, Staph aureus. Some of them in
Oh,
chain,
sorry.
it's strep.
Oh,
But
oh,
both
sorry.
cocci. The rods, you
Yeah.
have this new Pseudomonas and
Yes, yes, yes.
the other stuff. Okay, so that's what you got right now, and your antibiotic is working. The one that we ordered is good for that. There's one thing, Tylenol. Let's give her Tylenol.
Let's give him Phenergan for his nausea
Finnergan, yeah,
vomiting.
excellent. Yeah, that's a good one. Finnergan.
Um,
What else?
Tylenol for headache and fever. Yeah,
Okay, what else?
that's it.
Let's check PT and stuff like that too. What else? What do you want to do? Yeah, let's give him DVT prophylaxis,
Yeah, and let's give him.
pneumatic compression. We check his vitals.
You wanna give him what else?
Head elevation, that's important here.
Input, output, urine,
Yeah, put him on NPO, input, output. What else?
respiratory isolation.
Okay, yeah, that's a good one.
Um,
And then let's do CBC, CMP every day. I just want to monitor his infection that's going down. For
yeah,
any
but
infection, I would love to do that. And pulse
you're not.
ox, I'm gonna do it every 2 hours.
But listen. You're not moving the clock forward at all. How are you? How are you supposed? You're not even seeing the results of.
No, I'm imagining that I see, like it's not the. Yeah,
Oh,
yeah. So maybe I should
oh.
move him further. Yeah, you're right. Yeah, but I'm
Okay.
imagining that I moved it somewhere. Yeah, because these.
But you won't have. Okay, okay,
Yeah,
that's fine.
these practice cases of like of the thing is very important, and there is no interaction, so I'm doing them as an interact.
I see.
So how often do you want to do vitals? What's going on? Head elevation doesn't
I
matter.
don't know.
Yeah. Input as well. Like every 4 hours, you can do that.
Hmm. The reason I'm saying this is because my cases don't even go to this long. Like my case always ends every time I do like the right management. I don't even get a chance to like, what are you doing? I don't get the chance to even order these things.
No, like this one, you order it like the one that I ordered. It's not like something in. I ordered PTT,
Yeah.
NPO. That's and
Okay.
bed rest, head elevation. This thing you
Okay.
order it the moment you admit him.
I see. Okay.
Okay, so it's not. So there are orders actually the for anyone you admit.
Hmm.
Do you remember what it is? Like there is a mnemonics called V panic.
This is for admit.
Yeah, anyone you admit, you do something. Huh?
Vitals.
Yeah, V panic. V vitals. P prazole for if there's a high risk for
PPIs.
PPI, especially if the ICU on prazole. A for activity, you gotta see bed rest and stuff like that. N for if you put them NPO or something. I input output. Okay,
Hmm.
panic. N for NPO and NG tube. If you wanna put that, like it's different from case. And yeah, V panic. RW. R repeat the vitals.
C.
That's an important. W weight. You check weight and stuff like that. Okay. So that's the thing. Before any
What?
before any procedure, what do you order?
PTPTT.
Yeah, so you order these
Hyphen.
huh?
Hyphen screen.
So you order these things. They call it NBC pipette. NBC N put them NPO. B blood type. C to C2 consent and CT scan if it's cancer. Okay, and
Hmm.
P for PTT, PTT and INR. I for IV fluid and IV access.
Okay. What was the C in V panic?
Compression.
Oh, compression.
Okay, yeah, and NBC pipette you get E you put EKG. Okay,
Yeah, I have my other mnemonic, but I've been using that. So the first one I already know. Like it's like automatic for me.
which one? The pre-op?
Yeah. No, not the pre-op, the other one.
Hmm.
The one that I told you yesterday.
Yeah, but this one doesn't cover the pre-op like this one. You cut the glen, right?
Yeah, cut clean. Cut clean, it doesn't cover pre-op. I said that one is for my initial. The pre-op is V panic. I like that one.
V panic. This one is for the admission, not for
Oh, this
pre-op.
is. Oh, what's for pre-op? What's the mnemonic for pre-op?
It's called NBC2 Pipette.
NBC.
Yeah, you know NBC. Maybe there's a channel called NBC.
Yeah.
Yeah, Pipette. You want me to write it for you? I can write it.
Can you like show it or write it? Because I don't know what you're saying. Sorry.
Yeah, no problem. Yeah. NBC2
Oh, two.
Pipette. Okay.
Oh, pipette.
Yeah, puppet. Yeah. So you can. So this you put
And what?
NPO,
NPO.
blood type.
Blood type.
Okay, consent
Consent.
and CT scan if you need it. P. What is the P for? PTT.
PTT. INR.
PT. So this PT, you just write PT and you'll see all of those. You can just control
Mm-hmm.
and IV access. What else?
No, I is not IV access. I is input output.
Yeah, IV access and input output.
Oh.
Okay, and IV fluid actually. It's just IV fluid. That's what they are. They didn't put input output. So this one for admission. Okay, V panic has input output. So
Oh yeah,
just
you're right.
IV access and okay.
P
So
for
yeah. So
P for P. Mm,
yeah. So this maybe this one for P, one for PTT. Yeah, and the EKG,
mm,
ECG, and T for what?
temperature.
Tumor marker.
Oh.
Okay. And you have V panic. What is this for? V panic or W? Do you remember? Vitals.
Title. PPI.
Yeah. What else?
Um.
Activity.
Activity. NPO.
Beyond G2. IV access. IV fluid. Input output.
And compression.
Compression. Okay. Repeat vital.
Mm-hmm.
Wait. That's it. Okay.
Panic. V. Panic. R. What is RW?
R repeat vitals. Y W wait.
Okay. Okay. Thank you.
You welcome anytime. All the time. Yeah, so basically that's what it is. Like with this case, there is not much to be done. Just repeat
We
the.
just ordered. We just ordered like a million things.
Yeah, like yeah. This like just the most important thing is the antibiotic. To be honest with you,
Yeah. Yeah.
everything else is just like extra.
So can we cover the antibiotics as a revision real quick? If somebody is a baby, we give the same antibiotics, right? Under 6 months?
Yeah, but if it's less than 1 month, you don't give him ceftriaxone because this can cause hyperbilirubinemia and kernicterus. So you try to
So
give
what do
him
you?
cefotaxime or something different.
Oh,
Okay? Yeah, that's so that's what I want you to know, okay? If there is a neurosurgery or trauma, then you change, you give cefepime plus
okay.
vancomycin. Okay? If they are immunocompromised or elderly, you give them, you add ampicillin to ceftriaxone and vancomycin. Other than that, just ceftriaxone and vancomycin.
Okay.
Okay, that's it. So, and then you change the antibiotic according to organism and sensitivity.
Hmm.
Yeah. And don't forget to stop the initial antibiotic and change them to according to the antibiotic.
Mm-hmm,
And how often do you follow up with this patient?
Follow up as in like after discharge?
No, like during the hospital, you every 12 hours you check on him.
Oh,
And
okay.
yeah, and you discontinue CBC and BMP.
Okay.
Okay?
Mm-hmm.
So how do you summarize this case for me, like in a few words?
So, um, anybody who comes in with fever and altered mental status, headache, when you do a physical exam and you find the neck stiffness and the Kernig sign, you should automatically have meningitis as one of your differentials.
Yeah.
And meningitis is something that needs to be treated right away with antibiotics because it can very high mortality. So we want to order everything in, cultures, everything, and then we do want to do an LP as soon as possible and start antibiotics. And we do antibiotics according to the patient's age and the sensitivity. So if you're waiting on the cultures, we start off with ceftriaxone, ampicillin, and vancomycin for this age group, anybody above 50, and that's it. That's how you manage the patient, and you make sure you check on them every 12 hours.
How about if I tell you he had right arm weakness? How would the management different? Like with the same thing, everything the same.
Right arm weakness. Mm, like, are you saying that he has some electrolyte problems?
So whenever you have right arm weakness, like focal neurologic deficit, then you order CT before lumbar puncture. So this is very important.
Oh,
Okay. And the other important thing, you order blood culture before starting antibiotic. You never start antibiotic before because this is gonna mess up with the results.
yes.
Okay. How
So
about
you
if the
order head
hmm? Yeah, go
you
ahead.
order head CT before if you have any focal neurological deficit.
Excellent. Yeah, yeah. But this patient did not have, so the CT is not because sometimes if they have hemorrhage and you did lumbar puncture, you
Mm-hmm.
basically screwed them up. So you have ankle herniation, he's screwed for life. Yeah, yeah.
Oh,
So you don't want to mess up with him.
oh, that's true. Yeah, LP is gonna like increase the pressure.
Yeah. How about if the patient uh, have seizure and focal neurologic? Yeah, LP I think decreases the pressure. That's why they will have herniation. Yeah, I think.
Mm.
Yeah. So how about a patient have seizure with focal neurological deficit? What should you do?
I would I don't know. I would look for an abscess.
You add IV acyclovir with the empiric antibiotic.
Oh,
Doesn't it? So when do you order cryptococcal antigen assay? We did
when they
not
are
order it here. Huh?
HIV positive.
Yeah, exactly. Yeah, that's when you have
Hmm.
HIV.
Oh, so I didn't know seizure and focal neurological deficit. So you're actually trying to rule out encephalopathy.
Yeah, yeah. So how about if patient less than 3 months? What do you do?
Same thing, ceftriaxone, ampicillin, and vancomycin.
No, you give cefoxitin plus ampicillin.
Oh, sorry, cefoxitin. You just told me that. Shoot.
Okay, and you add dexamethasone for H influenza meningitis.
But you don't give dexamethasone to any other age group?
If you suspect meningitis, then you excuse me. Do you mind?
It's only for under 3 years old.
Yeah, yeah, under 3 months.
Mm-hmm.
Okay, good.
I mean,
How
three
about
months.
yeah? How about immunocompetent children has more than 3 months to adult of less than 50 years? What do
Mm-hmm.
you give him?
Ceftriaxone and Vanco.
Excellent. That's it. How about above 50 or
You add
individual with alcoholism or other debilitating illness? Okay, what should you do for these three groups? Hmm? Hello?
you would I'm no, I'm thinking, sorry. Um I guess you're gonna cover listeria, legionella, I don't know, Klebsiella. Um I'm not sure.
So you give them Ceftriaxone, vancomycin plus ampicillin.
So ampicillin still, right?
Yeah, yeah. How
Okay.
about someone who developed meningitis after head trauma or a neurosurgical procedure or a patient with a neutropenia?
Hmm. I'm not sure.
You give him antipseudomonal. Which cephalosporin that kills pseudomonas?
Iron cefotaxime. I'm not sure.
Vancomycin plus
Mm-hmm.
ceftazidime. Okay, so if you gave him like this guy, you gave him ceftriaxone, vancomycin, and ampicillin, and then you did the culture, and you found gram negative bacilli on gram stain, like CSF gram
Hmm.
stain. You found. What do you do right
Grams negative bacilli.
now? Yeah.
I don't even know what that is. You tell me.
So you switch it from ceftriaxone to ceftazidime because this is pseudomonas. Gram negative bacilli means pseudomonas. Okay.
Hmm.
How about if you find gram positive cocci in clusters?
We're already covering for that.
Hmm?
Mango.
You give him IV nafcillin.
Okay.
Okay, and first generation cephalosporin don't not used for staph infection because they don't have high permeability to CSF. How about if patient penicillin allergic and he's having methicillin resistant staph aureus? Then you give him IV vancomycin. How about the culture? If the culture shows only Haemophilus influenzae, what do you do?
Um. I don't know. I don't know antibiotics.
Yeah, you just give him ceftriaxone.
Okay.
That's all. What you don't need vancomycin.
Yeah.
So if the patient have meningococcal meningitis like rash, arthralgia, what do you think is going on?
When a patient has rash after penicillin.
No, no, like meningococcal meningitis. So they recommend testing for complement deficiency, C6 to C9.
Mm-hmm.
Okay, this. So how about if you find listeria?
We already said add ampicillin.
Yeah, how about listeria in immunocompromised or someone who's going through dialysis?
You give them ampicillin and antifungal or antiviral. I'm not sure.
So they say you add IV gentamicin and IV ampicillin plus IV gentamicin.
Mm-hmm.
Okay, so
What
yeah.
did you What did you say about meningitis with rash?
So meningococcal meningitis, it's specific, like present with a rash.
Mm-hmm.
Okay, that's the thing with it.
Oh.
Yeah, that's a difference thing with the. So you add. So you could test for complement because people
Mm-hmm.
who have terminal complement deficiency they tend to have recurrent Neisseria meningitis infection. Okay. Excuse me. Let me just put IV access to my laptop. It's like it's having hypertension right now. Like it's.
It's having hypotension.
Yeah, now undergoing having shock, hypovolemic shock.
Mm-hmm.
Let me put the IV access. Yes.
Oh, is that why it's blinking?
Boom. Yeah. Now I got it. Now you see the IV access right here. See, it's good.
Yeah, I see it. Yep.
Yep. Yep. There's IV access, IV fluid. Okay. Sounds good. Okay, so now let's go to the next one. Okay, ready?
Yes.
Yeah, so if you get confused with everything I said about antibiotic, just
Yeah.
remember you change according to the culture results. If you
Mm.
have a gram negative, you give ceftazidime. That's the number one. And if someone above 50, you add ampicillin. If
Yeah.
someone have a neurosurgical procedure, you give ceftazidime also for the pseudomonas. Okay, that's it. Pseudomonas is a nasty bug and it's very hard to kill. And
Mm.
MRSA too. So you just gotta be careful. Okay, so let's do another case.
That was a long case.
Yeah, and it's a tough one. Yeah. Let's see. So now, 50-year-old lady with a present with a history of chemotherapy post a successful breast surgery came to the ER with fever. So she has chemotherapy and she's a fever. Okay, you got what's going on. Let's see. I'll give you more history. So the temperature is 38.7. Respiratory rate is 18, heart rate is 80, blood pressure 130/70, okay? Now, you look at the HPI. She has history, post successful breast surgery, came to the ER with a fever. She was diagnosed with a breast cancer 3 months earlier, and she underwent surgery that was followed by 2 cycles of combination chemotherapy. Boom. So something. She was advised to come back to the office if she developed any fever. She denies cough, cold, headache. So this is called neutropenic fever.
Yep.
Okay, medical history, she had reflex osteoarthritis. She takes lansoprazole every day, acetaminophen. Denies smoking and IV drug and everything, so you don't need to counsel her on that. She is allergic to sulfa drugs, codeine. Review of system is aromatic. And she's 50-year-old. You know, after we do everything, we do screening, mammogram, and colonoscopy. Later, we schedule them for later, okay?
Mm-hmm.
Just remember that. Okay, now she's in the emergency room and she's stable. What do you want to do right now?
I don't know what you do for neutropenic fever. I
First
mean, I
comes
would,
first. Let's just examine.
yeah, let's just examine her and then just order our normal basic labs. Give her some Tylenol. So she has neutropenic fever because of chemotherapy, right?
Yeah, I'm suspecting pseudomonas to be honest, like because she's chemotherapy, neutropenia, and stuff. But we'll see what happens. I don't know. We'll see what's going on. Okay. So she has completely normal physical exam. Okay.
Mm-hmm.
Now what do you do?
I'm gonna order probably start the IV access. Give her Tylenol. Check her vitals. Give her oxygen, maybe, I don't know.
We'll do pulse oxygen. Okay.
Hmm.
IV access. What else? What do you want to do? CBC, CMP,
Yeah, give her Tylenol.
Tylenol. Okay, of course.
Yeah, okay, see,
So this
I'm
is
gonna
so now there's
check.
infection workup. Okay, so that's what any infection workup, blood culture,
Hmm.
urine culture. Okay, you do chest X-ray. You know, sometimes we can use mnemonic, but sometimes like you can if you make sense of it. Like it will be more fun. Like blood culture,
Yeah,
culture, urinalysis. What
yeah,
else? What do you suspect? Like she's having fever. We don't know the fever where it's come from, right?
yeah.
Okay.
EKG.
Sputum. Hmm?
Do a EKG anyway. Sputum culture. Do an EKG.
EKG. Yeah. Right. What else?
Um,
Give her IV fluid. That's okay. What else? There's one important thing I want you to know. She's in neutropenia and she's chemotherapy and fever. So I suspecting neutropenia. So do you want to give her some sort of antibiotic? Or do you have a bug in mind that you want to cover?
I have no idea. I suck at antibiotics and these bugs.
Okay, let's order the thing and we'll.
Yeah, I don't know like what bug goes with what. Like that's my weakness.
Oh, okay.
Mm-hmm.
Yeah, we'll take care of it here.
Yeah, I get stuck at the antibiotics part.
Yeah, so let's order because you remember always blood culture and stuff before the antibiotic. Oh, what happened? I did rectal. Damn. No. Okay, I was running fast. Just X-ray. Let's do portable. That's okay. Your analysis. What do you want to do? What's sputum? The first thing, gram stain. That's important. What
Gram stain.
else?
Culture CNS. Or spoon culture. Why not?
Yeah.
It's on the second, third one, the third one from top.
Yeah. What else? Do you want to do anything else?
I mean,
Pneumocystis is present bilateral interstitial filtrate. I don't know, suspect. Maybe fungal. I don't know. Legionella. We can do it. I mean, it doesn't matter.
mm-hmm.
Doesn't hurt. Sputum fungal stain using fake. No, the other one I don't need them. AFP smear is enough. You know, it's always good to drink water, so just give her some IV fluid. And now I give her the antibiotic. That's what I want to use. It's called ceftazidime.
Ceftazidime, that covers, you said, Pseudomonas.
Yeah, exactly. So the third generation cephalosporin, there are two types.
Mm-hmm.
Ceftriaxone doesn't cover Pseudomonas, and ceftazidime does. Okay, just put her IV continuous. Now, what do you want to do?
I don't know. Move her into.
Let's check some results and then we'll move her.
Okay.
Yeah, let's move her to the inpatient unit. Okay, so when you move her to the inpatient unit, what do you want to do? Remember, V panic,
Yes. Yes.
vitals.
Vitals, PPI, bed rest with bathroom privileges, and
She
PO.
has PPI. Okay, panic. A activity. What is it? What do you want to do? Bed rest. Yeah, okay. What
Mm-hmm.
else?
NPO.
And beyond. And what else?
Input, output, and compression stockings.
What else? V panic. RW. Okay, vitals. Repeated. Yeah, V panic. That's it. NIC. Okay, yeah, we got it. Oh, it's already. What is it? Bed rest complete. Okay. Think I gotta write pneumatic compression.
Are you gonna consult her to the oncologist? No, right? Or hematologist? Or no?
Yeah, we can always. Consult. Let's consult infectious. I think is better.
Oh, okay.
Okay. So matter of fact, why did we put her in PO? We can just put her in regular diet, right? She
Mm-hmm.
doesn't have like any problems, so just give her a normal diet.
Mm-hmm. So you cancel her NPO?
Yeah, yeah, I cancel that.
I hate when you go to the hospital and they put you NPO because then you're like, I wish I ate before I went.
Yeah, exactly. Yeah.
No, it happened to me when I was in labor. I went to
Okay.
the ER, the hospital, and they're like, "Oh, no food." I'm like, "Wait, I didn't eat anything all day." And then they didn't,
Wow.
for 16 hours I was in labor, they didn't give me food.
Wow. And you feel hunger, right?
Yeah, I was dying. I'm like,
But
"Oh
they
my
give you, even though they give you fluid, but the stomach still like you feel hungry and
God."
stuff.
So I was like, next pregnancy, I'm eating a big meal before I go.
Wow. Damn, that is hard. Wow,
I
that's tough.
was, I was so angry.
Yeah, I wouldn't imagine myself being like able to tolerate pregnancy. Like it's tough, it's annoying. I know girls have like superpower, like to tolerate that. Yeah,
Yeah, it just reminded me of NPO. I'm like, oh God.
yeah. Team, it's hard. Yeah,
Mm.
and you have to do breastfeeding and stuff like that. Wow.
Oh yes, the whole
Yeah.
9 yards.
My mom, she always still tell me like I breastfed you for 2 years and a half. I didn't use formula on you and
Oh wow.
stuff. Yeah.
Yeah.
So now let's do CBC and CMP daily and do PTT.
Yes, yes.
Okay. So what else? What do you want to do?
Is she even getting better with the Pseudomonas anti-pseudomonal drug?
Yeah, she's getting a little bit better. But the thing is that white PC, you have the blood, the neutrophil is really down. So what do you do? You can give her something. It's called neopogen. You know what is that?
No.
It's a granulocyte colony stimulating factor. It's to stimulate
Oh,
the neutro.
GMCSF. Oh yeah, GMCSF. Yeah, it plays a role like increases your neutrophil count or something.
Exactly. Yeah.
I mean, not neutrophil, the leukocyte count.
Yeah. Let's see her the next day. See how is she doing. No, let's just see how she's doing. We don't need all of that.
So this would be like a case very straightforward. Once you put her on anti-pseudomonals, you put change her to the ward, and then usually that's it, right? You just manage her.
Yeah. Now we just check her every day. See.
Neupogen. I had no idea about that.
Yeah, that's for anifibrar neutropenia. Like, you don't use any other case. Now you see how is she doing another third day. Okay, let's assume she's getting better right now. So what do you want to do?
Discharge her. Are
So
we gonna vaccinate
let's
her?
let's discontinue the IV. Yeah, obviously. The IV antibiotic if she developed well. Discontinue the CBCQ daily. What is it? Supposed to be CBC. Okay. Discontinue, and then you do just counseling, education, assurance.
Seat belt, colonoscopy, mammogram.
Exactly. Mammogram. Col- colonoscopy.
Yeah, seat belt,
Pap smear.
pap smear, seat belt.
Yeah. Seatbelt gonna be in the counseling. What else do you want to do?
Oh,
Anything right now? Let me give her some vaccine, maybe influenza.
vaccine. Yeah.
I don't know if I want to give her any other vaccine. Let's see. Let's see. Let's look at her history. No.
I'm counseling alcohol use.
I mean, it's okay. Restraining order? Wow.
That's the first time I saw that too.
Uh,
It's probably for like a psych case.
okay, yeah, these one, yeah. These one will order them in the 2 minute screen so that you schedule them later. We don't need to order it right now. Even if influenza vaccine, we order in the 2 minute screen. I
Okay.
don't know, yeah, this one I paused by mistake. Yeah, so basically just keep seeing her every day and if she's doing well, just send her home. Let's see how she's doing. Headache feeling a little bit better. Wow, even though we're not managing this case, but he felt better still. I don't know what did I mess up with him, but poor guy. I feel bad for him. How old is he, this guy?
You made him stay for 4 days and he feels better.
She's 55-year-old girl with hypertension. Wow, feel bad for her. I gave her so many things.
Mm.
Okay, yeah.
You,
So that's
you know something? The cases overlap with the software. So if you, whatever case you want to do, you can use the software and use the actual case.
like
You know
what
what
do
I'm
you mean, huh?
Okay, so go back. This is a ccscases.com, right?
Yeah.
Go to the main page where you see all the cases.
Let me
And I'm
see.
gonna show you because you're using like wrong like other cases to do it, but that's like
What is it?
so
Yeah.
go to view on top next to the help,
Yeah.
toggle diagnosis, go to diagnosis, click on the diagnosis on top where it says diagnosis. Now it's gonna put the diagnosis in alphabetical order. Now you look at the diagnosis you want and actually do the case. They have all the cases here.
So you mean this?
Whatever this way we can actually use the right simulation for it. You know what I'm saying?
You mean all the cases for the exam and stuff?
Yeah.
Oh, I see. Yeah, yeah.
So so if you're doing the U world and the next case you do whatever, look for it. It should be in there.
Yeah, yeah, you're right. Yeah, actually, yeah.
So at least we can use the actual simulation to see if the patient's getting better or what, and we get our score, you know?
Yeah, you're right. Yeah, that's a good idea. Yeah. Yeah, the only reason because I got many friends they discouraged me from using this. They said just to focus on your work. This is it's not important, just a waste of time. Like, if you just do your
No,
work.
it's actually very good
Yeah, it's just good to practice. Yeah,
for
you're
practice,
right.
yeah. Like
Yeah,
you and I, we're practicing. So I want to use the actual, I mean, you don't have to use it. I'm saying for our purpose.
yeah, yeah. For our purpose. Yeah, you're right. Yeah, saying like because before I did not use it. That's why. Yeah.
Yeah.
Okay, so now let's. How do you summarize this case? There's a discussion.
Mm. Mm. So we had a lady on chemotherapy for which she ended up getting fevers, and she came to the ED. And the most common cause of fever after chemotherapy is for neutropenic fever. So we should think of the most common bugs that actually cause this, and Pseudomonas is the most common ones. So we are going to put her on cefotaxime that covers Pseudomonas, and we're also going to give her Neupogen. Um, it's the GM-CSF factor, and that should help her bring her fever down and bring her leukocyte count up. And we keep her for a couple of days, watch her, monitor her, and once her neutrophil counts go up a little bit, are they gonna go up or no?
Hmm?
Are the neutrophil counts gonna go up?
Yeah, obviously. Like if you just give her Neupogen and stuff, yeah, she'll be. Yeah. So how do you? Yeah, yeah. Go ahead. Yeah.
And then once, yeah, she's stable and she's good to go.
Well, how do you define neutropenia?
It's a leukocyte count less than 5,000. No, 4,000.
Actual neutrophil count less than 500 cells per mm.
Oh shoot, less than 500?
Yeah. So this can cause disruption of the skin barrier resulting from chemotherapy, result in bacteria into the bloodstream. So that's why causing bacteremia and the
Hmm.
site of mucositis in the GI tract. That's what causes this thing. Most commonly
You think?
gram-negative Pseudomonas, but recently you can find gram-positive too. So so if I tell you, patient have periodontal abscess too, plus fever, plus everything else. What are you suspecting here? What
Vib-
antibiotic do you give?
Vibrio.
I suspect anaerobes.
Anaerobes.
So you gotta cover the anaerobe. How do you
Hmm.
cover the anaerobe?
You give them um, Carbamazepine.
Yeah, or you can give them clindamycin and stuff like that. Yeah, carbapenem is
Oh,
very strong. When do you repeat the blood culture?
after 48 hours.
Yeah, after if they still have fever, then you repeat after 48 hours.
Mhm.
Okay. When do you order lumbar puncture as routine of neutropenia?
No.
Only if they have meningitis symptoms.
Hmm.
Okay. So now, how do you treat Pseudomonas? What are
With
the drugs of
and
choice? This can be,
you can
this discussion is helpful not just with the CCS, but with everything, like with even with the clinical medicine too. So it's both ways. So what is it, huh? What do you think?
so anti-pseudomonas you can give them carbapenems. You can give them third generation ceftriaxone like cefotaxime. You can also can you give piptazole? No, right?
Yeah, you can give that too. So this is you give there is monotherapy and there is double therapy. Monotherapy, cifepime, ceftazidime, imipenem, or meropenem. Okay. While double coverage, you give aminoglycoside plus extended spectrum anti-pseudomonal penicillin.
Mm-hmm.
Okay, that's how you split it. When do you add vancomycin?
When it's MRSA,
If there is no response in 2 to 3 days,
mm-hmm.
okay, then you consider vancomycin.
Mm-hmm.
Or if there is a surgical site infection, skin infection, history of MRSA, recent quinolone use, you add vancomycin.
Mm-hmm.
When do you add antifungal?
Mm, I-
So this is very good information. You remember we add vancomycin if it's no improvement in 2 to 3 days.
mm-hmm.
You add amphotericin B if there is no improvement in 5 to 7 days. Okay.
Mm-hmm.
So when do you use granulocyte colony stimulating factor?
When not sure.
So the benefit of colony stimulating factor is an adjuvant to antibiotic therapy in uncomplicated febrile neutropenic patient.
Mm-hmm.
Okay, that you give and considered with patient with a predictive poor outcome, such as patient with uncontrolled primary disease, pneumonia, hypotension. Okay, absolute
Mm-hmm.
neutrophil count less than 100,
Mm-hmm.
multi-organ dysfunction, or invasive fungal infection. For any
Mm-hmm.
of these, you give colony stimulating factor.
Mm-hmm.
Okay,
Yeah.
so as a general approach to the therapy,
Mm-hmm.
you'd use initial antibiotic of choice. C. Does the patient need vancomycin? If yes, give vancomycin plus ceftazidime. If no, just give ceftazidime or aminoglycoside plus extended spectrum anti-pseudomonal penicillin. If the
Mm-hmm.
patient became afebrile in 3 days, change to oral antibiotic, either sulfexime or quinolone. Okay. If the patient is still febrile after 3 days, okay, stop the vancomycin if added initially and culture are negative, add vancomycin. If not
Oh,
understood, if not administered initially. Okay, and repeat culture in three
okay.
days. Okay, and chest X-ray, repeat that.
Mm-hmm. Mm-hmm.
How about the duration of therapy? If the source of infection is identified, antibiotics should be continued for the standard duration. What is the standard duration for therapy of antibiotic?
I think 7 days.
14 days for Staph aureus bacteremia.
Okay.
How about if the source is unknown?
Maybe longer.
So this approach will be followed. If the patient is afebrile in 3 days,
Mm-hmm.
and the absolute neutrophil count more than 500,
Mm-hmm.
stop antibiotic after 7 days.
Right.
If the patient is still febrile and the antineutrophilic count less than 500,
Mm-hmm.
you just continue the antibiotic.
Okay.
Okay?
Oh, so after you check the neutrophil count, and if it's still 500, then you keep continuing it?
Yeah.
Mm-hmm.
Okay. So
Okay.
that's the thing. So let's do another one last case.
Okay, thank you. Mm-hmm.
And do that, yeah, you're welcome. Okay, so let's see this guy. Okay, so now a 28-year-old white female is brought to the ER in unconscious state. Okay, let's check her temperature. Temperature, they write it like TEM. It's like a tram, something, Yeah. So 37, respiratory rate is 10, heart rate is 50, BMP 100, right? Respiratory rate 10 tells you a lot, right?
Mm-hmm.
So family report that she's very healthy, female, has no medical problem, not on any medication, did not use any empty bottle, no allergies, she doesn't smoke or drink alcohol, she has a boyfriend, she has never been pregnant, her father is healthy, except borderline hypertension, mother is diabetic. Okay, that's it, no other history because she's, unconscious. So now it's a good thing to solve an unconscious case. So what do you want to do?
So basically, she's 28 years old, unconscious, with no fever, respiratory rate of 10,
Yeah, coma.
heart rate
Let's see.
50.
Let's see if there's. Do you think they have unconscious coma? Do they have coma?
You have to go to C.
What a minute. Do they line it by?
Alphabetical. You have to click on diagnosis again. Now you go C. Go under C. They should. I don't know. No, they don't. I don't know what they would call it. If they, I don't know if they would call it coma.
Altered mental status. Let's see.
Okay, never mind. It's fine. If they don't have it, it's fine.
Cerviculitis.
Unconscious. Nope.
Loss of consciousness. Let's see. That's last one. Okay. No. Oh no, it's okay. Yeah. Well, I'll give you everything.
It's okay. That's fine.
Yeah.
Okay. So first, I'm going to.
So now this is totally different case. Okay. So what do you do?
Okay, I'm gonna start IV access. I'm gonna give her thiamine. I'm gonna give her glucose.
Yeah, and this patient, blood pressure 100/60, heart rate 50, so it's like she's almost unstable, right? So what do you do?
Yeah.
Okay, go ahead.
IV access.
Okay,
IV fluids. Um. Um. Glucose stick. Finger glucose. Because we have no idea what's wrong with her. We have to figure it out.
okay, what else?
I'm gonna give her thiamine.
Okay, do you know what is the coma cocktail?
Yeah, thiamine. Hold on. Don't tell me glucose and naloxone.
Excellent, yeah. Okay, what
Um,
else?
then we have to give her urine toxicology.
Excellent, yeah.
I'm gonna check her alcohol, TCA serum, alcohol serum, um, salicylate serum.
Okay.
TCA serum.
CMP serum, okay.
Do for salicylate serum.
Okay.
These are like the common overdose drugs.
Yeah, okay, what else? And put a cardiac monitor, BP monitor.
Vitals. I'm gonna do an EKG on her for sure.
Yeah, what else? Did we
Um,
do pulse ox? Let's see.
no, you
Oh,
didn't.
okay, pulse ox.
We're not even using the mnemonic.
Yeah, oxy,
Oxy.
oxygen. We'll see everything. Okay, what else?
That's it. Let's order it.
Dextrose. It's better than glucose. Let's see. Okay, what else?
Mm,
ABG, you know.
yeah, ABG. Can we do glucose coma scale or what is it called? GC scale?
Glasgow Coma Scale. I don't know. Is it present? Let's see if this was Glasgow Coma Scale. I don't know if it's present in the software. Let's see.
That's it.
So she's unconscious too. So the first thing we protect. What are the indications for intubation?
I'm not sure the exact indication, but I think if their respiratory rate is really low and they're unconscious and they're unstable.
So ABG gonna decide that. So we'll do suction airway now. And the
Okay.
ABG, if it's less than 55, we do intubation. Okay. Let's
Mhm.
go. Yay. I like when I order so many stuff and then
Mhm.
continuous IV, domestic glucose, thiamine therapy. What's going on? Naloxone.
Oh, they have this case. I know which case they have it. They have it in the system. It's called narcotic overdose
Really?
in the software.
Yeah, that's okay. We started this already. So
Yeah.
salicylic acid serum, you said?
My daughter just woke up. Give me 1 second.
Okay.
Okay, I'm back. I'm sorry.
Okay, no problem. Yeah, now, so with the treatment that we ordered, she feels a little bit better, and we did physical examination. I did look at the PO2. She doesn't need an intubation and stuff.
Okay.
Okay, so now what do you want? Let's just admit her. I would want to admit her.
What was the reason? Why was she comatose?
So in physical examination, we found a pinpoint pupil. So it's most
Oh,
likely not.
heroin. Opioid
Yeah,
overdose.
bradycardia, hypotension. Okay, so she's drowsy too. So this could be any of that. So now let's do the inpatient order. You remember?
You saved her life.
Yeah, yay! We both saved her
Okay.
life.
Vitals? No, use the mnemonic.
Okay, okay,
Vitals,
yeah, yeah. Vitals.
PI,
Yeah, pulse,
bed rest.
bed rest. What is it? PP pulse. Okay, pulse activity, panic, and. But do you want to put it on NPO?
Yeah, NPO. Input
Let's do
output.
NG tube. Because
Why you wanna do anti-tube? That's invasive.
because she's comatose and she may not be
But
like we give her feeding through NG tube. You can give put an NPO, but NG tube works too.
okay, sounds good.
Yeah. What else? What else? What do you do? And input output. Yeah. Input.
And compression? She doesn't need compression.
pneumatic
Does she?
compression. Yeah, we can just order. We're not gonna lose anything. And then since we suspect opioid, so what do you want? You want to give her charcoal?
Activated charcoal. I'm gonna do like a suicide counsel to her on her.
Okay, let's do beta HCG. She's a female. What else? Let's do
Do a
chest X-ray.
suicide. Do counseling.
Yeah, maybe we can do. Let's stabilize her now.
Okay.
And let's do CMP every day. Okay, that's just vitals. We already had that.
The NG tube is indicated in which cases? Only comatose people know, right?
Yeah,
Abdominal.
like comatose. You can do it in comatose people and stuff, and you can even put them on NPO. It doesn't matter. Like no, it's not a big deal.
Mm-hmm.
Alexoma. This is already. This is the portable. CMP. This one put every 24 hour. What's going on? Every 1 day. So now let's just see her next day. Okay, let's just see how she doing. Let's see how she doing now. Okay, so she feels better after 1 day. So what do you want to do right now with the orders?
Now I want to counsel her.
You want to discontinue some stuff? Discontinue.
Mm-hmm.
Let's discontinue the NG tube. Discontinue oxygen. Discontinue dextrose. What else? Let's discontinue that. Discontinue naloxone. What else? Discontinue thiamine. Okay, let's give her regular diet,
Mm-hmm.
Anything else? Now, let's just do psychiatry consult.
Mm-hmm.
What else? Suicide stuff. Counseling. Reassurance. What else? Let's see, how old is she?
I would do influenza vaccine. That's about it for her age. Nothing else.
Suicide contract precaution.
How are you able to do this? I can never do this on my end.
Why? You mean like control?
Yeah, it doesn't work on me. I do have to do shift, and then the shift highlights everything.
Damn. Yeah, this with Mac, I think. Only with Mac. So on the real exam, you're not gonna have that.
Yeah, I have Mac. Yeah.
Yeah, but although, I have Mac, but it works. I think maybe you use a different browser.
Oh, I use X. No, I don't have a browser. This opens up
Use,
in the.
yeah, in Safari, right?
No, it doesn't open up in Safari. It opens up. I have the software. It opens up on its own.
In this
And
software. Yeah, but in New World, I think in New World you can.
oh, in UWorld, yeah. This is UWorld or this is
No,
CC?
this is CCS, yeah. Oh,
Okay.
yeah, maybe CCS, yeah. Maybe it's because of Mac, yeah, because Mac.
Mm.
Okay, so now we canceled her everything. So what do you want to do? Let's see the psychiatric consult if he needs to put her
Mhm.
on SSRI or something. Maybe she's depressed. Let's just put her on citalopram.
No, you should do a depression index before you do that.
And yeah, if the psychiatrist recommend that, let's assume that the psychiatrist recommend that. You can do depression index.
Hmm.
Have you ever felt depressed?
No.
Really, never. That's good.
I mean, I wouldn't diagnose it depression, like maybe acute stress disorder.
Really? When? Probably the USMLE exam.
I mean, not even acute stress. What is it called? Adjustment disorder, maybe.
Yeah. Okay, so now she's doing well. So how do you summarize this case?
So we have a young female comes to the ED in comatose state with unstable vital signs. The first thing that should run in our mind is that intoxication of some kind of overdose or, you know.
Okay.
So right off the bat, we have to start the comatose cocktail of thiamine, naloxone, and dextrose, just in case if she does have anything, she will not get Wernicke encephalopathy. This is why we give the cocktail. And then we are going to run a whole bunch of tests where we're going to test for all the drugs in her system. We're going to do drug levels. We're going to do for drug toxicity. Urine toxicity. We're going to check for all the serum, all the common over-the-counter overdose drugs. And then once we check for that, then we kind of stabilize her, and check her ABGs if she really needs intubation. But if her ABGs are good, she doesn't need intubation. We just give her IV fluids and keep her stabilized, manage her, and then move her into the ward and then care for her from there. Keep checking her CBCs, keep monitoring her blood pressure, EKG, and vitals, and give her charcoal, and then basically that's it, and then counsel her.
Yeah. So first thing is this is drug intoxication. We start with baseline.
Hmm.
BMP, LFT, ABG, CK, creatine kinase also. We forgot to do that. That's an important one. And then you do when you find positive drug in 36 to 48 hours post exposure. Then you find out. Then you do EKG. Okay, because there is sometimes cardiotoxic congestion, and then you do chest X-ray
Hmm.
for pulmonary edema. That's why you do it. And you gotta be careful with naloxone in patient who has not used opioid before. You can give them naloxone continuous, but one who have used opioid before, continuous naloxone can precipitate withdrawal, which is very dangerous. So,
Oh,
so when do you do orogastric lavage?
in the
If
first couple of
in
hours.
first hour, yeah, if present in 1 hour of ingestion, you do lavage,
Hmm.
and charcoal. You do give charcoal also too. So all patients with recurrent with the significant respiratory depression, recurrent sedation
Hmm.
should be observed for 12 to 24 hours.
Hmm.
Most of them get admitted if they require second dose of naloxone and should have continuous cardiorespiratory monitoring. Okay, so that's about it. Okay, so let's just to summarize the cases that we did today.
Hmm.
Okay, just in a nutshell, just to end it with that. That's the first thing. We had the first case. You remember what was the first case?
Yeah, we had a meningitis.
Yeah, meningitis. We start with the police R, like what is it called? Police RW, the pulse ox and stuff like that, and then we do CBC BMP and infection protocol,
Hmm.
blood culture and stuff. We start him on antibiotic. Okay, and then we just monitor CBC and BMP every day and call it a day. That's it. And you gotta know we discussed the antibiotic coverage. The second case that presented with neutropenia. Okay, it's a very interesting case. You'd start with the police RW, which is pulse oxygen and IV access and all of these cool stuff, and then you do CMP, and then you give ceftazidime IV continuous. Okay?
Mm-hmm.
And then you just monitor CBC, BMP daily for any fever. Okay, if they improved in 3 days, that's okay. If not, add vancomycin. If they did not improve in 7 days, add amphotericin. Okay, and so
Add
on.
what? Oh.
Amphotericin.
Mm-hmm.
Okay, and so on. For fungal. If they improve, then that's good. You can add neopogen if there is especially if the neutrophil less than 100. Yeah. Now the third case, patient is present with unconscious state. It's present to the
Mm-hmm.
emergency room. First, you protect the airways. You do suction,
Yeah.
pulse ox, oxygen. This police RDW, cardiac monitor, and then you start coma cocktail, which is thiamine, naloxone, dextrose. Then you examine her, and then you do CBC, BMP, all of these kind of stuff, urinalysis, toxicology, beta HCG, blood alcohol. And I like that you ordered even serum,
Mm-hmm.
salicylate serum, TSA serum, TCA serum. That's a good thing you ordered. And then you move her to the ICU. Put her on NPO, bed rest, or an output, all of these kind of stuff, which is V panic. And then you educate her, counsel a psychiatrist, suicide prevention, and
Mm-hmm.
those types of things. And you order orogastric lavage, that's an important if you order it within first hour.
First hour.
Yeah, and most of the patients require second dose in 12 to 24 hours and require
Mm-hmm.
continuous second dose of naloxone and require continuous cardiorespiratory monitoring. And just be careful if you want a naloxone when they ask you one time or continuous. Just choose one time, don't choose continuous. Because if
Mm-hmm.
they can precipitate severe withdrawal and you don't want that.
Yes.
Okay, so that's it. And that's the end of the three cases. It was a very fruitful discussion. We dissected three cases, so that's good.
Mm-hmm.
We'll continue from tomorrow. Then, do you have any questions, concerns?
No, thank you so much for today.
Okay, you're very welcome. Okay, so I'll see you tomorrow then.
See you tomorrow at
Have a
9.
good night. Bye.
Thank you, Mom. Good night.
You're welcome. Bye.